Now we're going to talk about Chapter 2, the spectrum of care. In this chapter, the learning objectives that I'm going to be expecting are to define the concept and components of population health, to identify the determinants of health and their effect on healthcare, also to discuss the social and economic imperative of health promotion, define the concept of disease management and understand the business case, and also to identify the need for and value of integrating healthcare services into the community, including work sites and healthcare institutions. All right, so what is population health? So now, obviously, it's a cohesive, integrated, and comprehensive approach to healthcare that considers the distribution of health outcomes within a population, the health determinants that influence distribution of care, and the policies and interventions that impact and are impacted by the determinants. Now, a successful population health relies on the coordination of multiple interventions, such as health promotion, prevention, screening, behavioral change, consumer education with a special emphasis on self-management, disease management, and chronic care management. Now, we're going to discuss each one of these throughout this lecture. And also, too, population health serves as a building block for many state-based programs and the National Priorities Partnership, or NPP, as well as Healthy People programs. So, we talked a little bit about this on last chapter, the chronic problem, talking about the chronic illnesses. Heart disease, stroke, cancer, diabetes, obesity, arthritis are the most common, costly, and preventable of all the problems. Almost half of the adults have at least one chronic healthcare condition in the United States. More than a third of the adults are obese. 80% of healthcare spending is dedicated to treatment of these chronic conditions. So now let's talk about the population health paradigm. A healthcare delivery approach that addresses the underuse and overuse of healthcare resources, seeking increased clinical quality at optimal expenses via patient-centered care. Personalized patient-centered care that includes self-management, shared decision-making, health promotion, disease management, and case management. Also, this will happen via responsible primary care providers, such as maybe even a medical home, patient-centered medical home, obviously, assessment of health determinants, clinicians' knowledge about and the recognition of health determinants and their effect on population and individual health. So obviously, to know which health determinants are out there definitely will help toward helping patients. Clinical, public health, and community integration. Evidence-based guidelines. So by using these evidence-based guidelines, it helps to provide quality, cost-effective care. And then obviously appropriate health education that promotes self-care as well as health information technology. Health promotion encompasses activities to maximize the development of resistance to threats of health. So this process is enabling people to increase control over their health and its determinants and thereby improve their health. This also helps promotions to reduce avoidable expenses, the clinical burden of chronic illnesses, and the unsustainable trend in healthcare costs. So on January 1st of 2014, the Affordable Care Act was signed by President Barack Obama. This has required that all new health plans inside and outside the health insurance marketplace cover a comprehensive package of items and services. This is known as essential health benefits. So this must include 10 different services, and these services can include ambulatory care services, emergency services, hospitalization, maternity and newborn care, mental and behavioral health services, prescription drugs, rehab, and habilitated services and devices, lab services, preventative and wellness services, and chronic disease management and pediatric services. Now, prevention is the interlocking and mutually supportive strategies and interventions aimed at the deterrence, early detection, and minimization of or cessation of disease and injury at a population level. Now, preventative activities and care are critical to the health of the nation's population and the economy. With about 70% of adults dying of chronic diseases and 75% of adults being treated for chronic illnesses, only 3% of the budget goes towards health promotion and prevention. So some of these prevention, the primary, secondary, and tertiary, primary prevention is preventing problems before symptoms appear. An example of this would be immunizations, using your seatbelt, not smoking. Some secondary preventions are early identification of asymptomatic disease to initiate treatment or cure. Some examples of this would be screening for detection of chronic illnesses like obesity, smoking, alcohol abuse, illicit drug use. And then tertiary preventions are aimed at slowing the progression of confirmed disease. And some examples here would be routine foot and eye exams for diabetic patients, as well as an annual stress test for those patients that have coronary artery disease. Now, the health benefits of preventative care are substantial. The short-term costs are actually really high. Now, for screenings, it's a presumptive identification of unrecognized disease or health risks by the application of tests or other procedures. So there are a lot of appropriateness of screenings: distribution of disease, evidence supporting screening, validity of available tests, potential outcomes, and these potential outcomes can be true positive, true negative, false negative, costs of unnecessary tests or unneeded care. So potential outcomes definitely help that. Benefits and risks of screening, availability and costs of treatment, and determinants of whether evidence-based and eligibility criteria actually exist. Now, talking about behavior change, it's an estimated 30 to 60% of patients are not compliant with their physician-directed treatment or medication regimen. Behavior modifications have become an integral part of the population health paradigm, modifying the physical, emotional, habitual, and cultural factors that influence health status. Also, too, paired with usual health care. So behavior change interventions have yielded positive patient outcomes in preventions of diabetes, hypertension, hyperlipidemia, stress, and to stop smoking. And also, behavior change relies on an interdisciplinary approach that relies on physicians and non-physician staff to educate, engage, and support patients in behavior change through shared decision making. So obviously the physician is going to recommend certain changes that need to be made, but it is up to the patient to actually engage in these changes and actually make them work. But also too, by help of the non-physician staff, nurses, clinicians, other people within the office organization will also help that patient towards making those behavior changes. Now, for self-care, consumers can readily learn to care for themselves, participate in goal setting, and engage in collaborative decision making with the appropriate education, skills training, and integrated healthcare systems. So self-care also aims to lower the demand for follow-up care due to greater compliance with health-promoting behaviors. Also, self-care seeks to have consumers reduce risks for themselves or through timely communication with their primary care provider. So engaged patients have a greater ability to identify potential health risks early, such as, again, blood pressure monitoring, self-exams, screening tests, and things of those sort. Now, patient-centered medical homes. This concept actually focuses on the management of chronic illness, improving patient outcomes, and lowering healthcare costs through evidence-based guidelines. Now, a medical home is a team-based approach that is patient-centered, comprehensive, accessible, committed to quality and safety and coordination. So, being patient-centered, this mainly will refer to provider and patient and family partnership that respects the patient's preferences. Under the comprehensive part of it, it's a team that is accountable for the patient's care needs. The accessible is ready in-person and remote communication access. Committed to quality and safety is continuous improvement. And then coordinated would be links to other access of larger care, including community services. Also patient-centered medical homes emphasize the monitoring, evaluation, reporting, and improvements of the quality of care and patient outcomes, and this will go along with the IT systems. Associated with reduction of medical errors, improved quality of care, and increased customer satisfaction. And again, that will go towards our triple aim that we talked about last chapter as well. Now, disease management has been defined as a system of coordinated healthcare interventions and communications for populations with conditions in which patient self-care efforts are significant. Disease management also seeks to reverse the incidence and prevalence of serious, costly chronic illnesses through quality and cost-effective care. And also, reports indicate it can reduce costs related to congestive and coronary heart disease, diabetes, and depression. And it also reports And also reports are showing an increase in work productivity while decreasing absenteeism, working while you're sick, and or hospitalizations. So health disparities occur when there are differences in the influence, prevalence, mortality, and burden of disease, as well as other adverse health conditions or outcomes that exist among disadvantaged population groups. And this can be based on socioeconomic status, education, age, race, ethnicity, geography, disability, sexual orientation, and or special needs. These population groups experience a disproportionate burden of illness as a result of barriers imposed by discrimination or differences in culture, language, beliefs, and values. And this leads to poor quality of care and lack of access to affordable quality primary care. A disenfranchised population tends to live in lower socioeconomic communities with higher rates of violence and environmental exposure, work in jobs with greater occupational hazards, they're less access to affordable healthy foods, and they also have higher rates of being uninsured. So for cultural competencies, you just need to understand the social and cross-cultural influences of different populations, values, health beliefs, and behaviors, disease prevalence, and incident and treatment outcome. Organizational, structural, and clinical barriers. Now this is where it kind of lack of diversity in institutional leadership, healthcare providers, and workforce, and it can correlate with consumer satisfaction. The lack of knowledge for healthcare providers to differences in ethnic, religious, or health beliefs and or values, and also lack of interpreters. So it can be a huge barrier if you're at a physician's office, you don't speak the language, and they don't have an interpreter readily available. Obviously, that can affect the actual care of that patient. Implementing interventions to assure quality care to diverse patient populations. And actually right now 6 states require and are in the process of requiring cultural competency training for physician state licensure. Right now 35 states have enacted legislation requiring provisions for language access. So they are in the process of implementing these new interventions to help with these cultural competencies so that the standard of care is improved for these individual patients. So there are some national and state initiatives that are in place to help toward achieving the goal of population health. The National Quality Strategy, which is a PPACA, mandated to identify quality measures and align local, state, and private initiatives to improve healthcare. Then you've got Healthy People Initiatives, which is a U.S. Department of Health and Human Services, or Medicare, program that sets national public health priorities over a 10-year period. And then you have states, which in addition to Healthy People as well as the National Quality Strategy, all have programs that address healthcare disparities to increase access to quality and cost-effective care, and also to improve healthcare delivery at manageable costs. And then finally, population health seeks to integrate health promotion, prevention, screening, behavioral change, self-care, patient-centered medical homes, disease management, efforts to reduce health disparities, cultural competencies, and national and state initiatives. So if you have any questions in regards to anything that we just discussed about in Chapter 2, please let me know. Otherwise, thanks for listening.